Hi, good evening to everyone. Thank you for joining me for another one of those big presentations. So, every Thursday, every so often, I will take on a very, very complex topic. And today, what I'm handling is this: when Hivicron arrives, predicting the next phase of the COVID storm. It sounds like a mouthful, but it really is taking inspiration from what Geert had said, where Geert had predicted this highly immune evasive Omicron variant that would cause great problems across the world. I have taken that concept, put it together with the research that I'm doing, trying to see if I can make sense of the two. And I've come together with a presentation that I believe is probably the closest to predicting what is going to happen next. It's a huge challenge, and this one here was far more complex than I thought it would be because I really had to push myself to try and get some ideas as to how to put across these concepts to you in a way that makes sense. So, as usual, if you're here with me on YouTube, you will get the first part of this presentation, but only the people who had registered for the webinar will be able to hear the full presentation. Remember, if you're watching it beyond this, there should be a link in the description which will allow you to take a look at the full presentation. This is very important. So, without further ado, let's get started with the first part of this discussion. This presentation was inspired by Geert van den Bosch in the sense that he has been looking out for a highly immune evasive Omicron variant that he describes as Hivicron. And therefore, the question is, what happens next in terms of COVID-19? Before I start, as usual, there's a disclaimer. We need to understand that this is information, this is research. It cannot replace you seeing your doctor or your emergency physician. And so please take this and understand what you're doing with it, but hopefully stay with me for the scientific journey. So, what is this Hivicron? It's technically a highly immune evasive Omicron descendant, shaped by the fact that you've had mass vaccination with viral circulation and the combination of this variant with immune suppression causing increased transmissibility of the virus. Big mouthful, but the principle is simple. Eventually, based on what Geert predicted, there is going to be a variant that evades the immune system primarily in highly vaccinated regions. That's the truth. He is not talking about Haiti or Papua New Guinea, where they have low vaccination rates and therefore they are in a situation where they have broad natural immunity. It is because of the focus of the immune system why his prediction is that this will occur. One of the problems is that people don't fully understand those concepts, but that is a whole different conversation in itself. Here is what I intend to cover: the overview of Hivicron and the disease presentations, the definition of the 5 types of manifestations, reflecting on how the disease will go to its terminal phase, and then potential strategies that could mitigate the impact. And so this is what I'm after here with regards to this presentation. So let's start off as usual with the basic science. Just remember your coronavirus. This is an unusual virus. We have never seen a virus like this one. But on the surface of it, these blue dots represent the spike protein, a trimeric spike. That means that every one of these points can bind to ACE2 to enter a cell. There are about 25 of them on the surface of the virus, and so therefore about 75 binding points. This is what the cut section looks like, and this here represents the spike protein. Remember, they are not just spike proteins. You also have membrane proteins, envelope proteins, nucleocapsid proteins. And then when the virus makes some of these into this RNA into protein, ORF 1A, 1B, that also can trigger the immune system. So all of those things together are quite relevant in terms of understanding what happens. The most important thing about disease in the future and the presentation of the disease is mucosal immunity from my research. What that means, if you can prevent the virus from breaking through this mucosal lining, preventing it getting into the bloodstream where it triggers systemic immune responses, you are in the best position. I cannot emphasize that enough. It's not whether or not people get exposed and localized infection. It's whether or not the virus is breaking through into their systemic circulation. And they usually know it by how unwell they feel. Mild infections with runny nose, sometimes a little bit of a cough and so on, that may not necessarily be so significant. But one of the most important observations I've had clinically is the association these days of fatigue and headache. Really insidious symptoms that many people overlook as to the significance of it. Now, as Geert had predicted, when he spoke about this, he predicted lots of variants because of vaccinating in the middle of a pandemic. Some people still don't agree with him, but this picture, in my view, from nextstrain.org, this is just showing here the Omicron spread into the BA1, then BA2, then XXB. That was one whole line here that ended up like this. But then we had a breakout of JN1 in about 2023, and that has just spawned a huge number of variants. This is incredible. And this is part of the reason why, no matter how hard they try to find a vaccine to therefore keep up with this, they can't, because these mutations are occurring so significantly and so rapidly. If you had continued just labeling these variants from alpha, delta, lambda, we would probably have run out of Greek alphabet names. So the fact that they're still calling it Omicron, don't think it is the same variant. It's just because they realized they'd never be able to keep up with labeling it. Here is now the prediction that Geert had made. What he was saying is that when you looked at the trajectory over time, this was the first phase. When we look at all the Omicron variants, then it accelerated to this, then it's accelerated now to this. So now variants are appearing every few months. And the question he's asking is what happens when it goes almost vertical, where these new variants are appearing in weeks or days? That's where we're going to see that huge crisis of these immune evasive variants. That's the challenge that Geert had been talking about. But my question was, how would disease present? What would it look like? And this is what took me some time to try and be able to piece together. But when it came, I thought this was very important. Well, here is what I saw. The full spectrum of what happens with Hivicron. Starting over here, persistent infection, immune dysregulation, smoldering inflammation, metabolic collapse, end-stage viral sepsis. And this whole picture is what I realize is that the population or a whole population can be put into all of these categories, except the ones who are largely evading many of these things with good mucosal immunity. The question is, why would this happen even in an immune competent population? What is the mechanism? And this is where we then have to remember this overview of the immune system. Simple stuff. I have used this as an analogy to the army, where your monocytes, very versatile immune cells, are your tanks. Neutrophils, basic pawns, are your foot soldiers. Your T cells are your air force. Your B cells are the missiles, and they produce the antibodies. Natural killer cells I've considered to be the Navy. The mast cell is on its own. This is what tends to trigger allergic responses, but is very relevant still in COVID-19. The problem is that when it comes to infection and when the virus breaks into the systemic circulation, it has to get past the mucosal immunity. And here is what it looks like. And this is very sophisticated. People think it's just a layer of cells. Not at all. You have a mucus layer, you have the cilia, you have IgA antibodies, you have performance inside there to attack bacteria, defensins, all kinds of products to fight against bacteria and viruses. And even if the virus penetrates this mucosal layer, it still has to get past the immune defense that is sitting right underneath it. So this is a very sophisticated system. And part of the reason why we've had problems in the pandemic is largely because it has been underestimated in exchange for systemic immunity, which is what happens when you inject, say, a vaccine. For respiratory viruses, especially rapidly mutating ones, the mucosal immune response is absolutely critical. But here is the problem when you have that virus getting into the systemic system. This is what happens to a lot of immune cells. The viral spike protein can disable these immune cells. They almost get stuck. As it's been described before, like zombies, they are there, but they are not functioning properly. And it is this mechanism that is oftentimes overlooked and underestimated, because if you look at the blood counts, other than the fact that the lymphocytes can be reduced, looking generally at blood counts, it may look apparently quite normal. But in reality, this is what it will look like. Your immune team is depleted. T cells, B cells, natural killer cells, leaving primarily the monocytes to do the versatile work, and your foot soldiers along to some degree with the mast cells. This is a depleted immune system. And this is part of the reason why, with an immune evasive Omicron variant combined with a depleted immune system and poor mucosal immunity, you then get this picture of circulating virus infecting cells, especially blood vessel endothelial cells, recurrently circulating all through the system and driving inflammatory processes. This essentially, in my view, is the process that takes an individual down the pathway of eventually end-stage disease. The question is when and how long. And this is further augmented when we think of the vaccinated cohort as a population in terms of IgG4. Remember, this antibody is immune tolerant. And so you can see, even with mRNA, no infection, it's up to 45% of the antibodies are telling the immune system to stand down. This will only augment the risk of ongoing viral circulation, which will increase the risk of the immune system becoming dysfunctional. So this combination of circulating virus interfering with immune cells, IgG4, ends up with an image that would look something like this. The gates is open, the security is tied up. How do you stop the intruder from getting to the house? That's the challenge that we're facing now. And depending on where people are, some people may still have the gate closed, but no guards. Some people may have one guard and the gate partially open. But together, all of these things are leading us down a road that causes further health issues. There's a very important thing to understand about severe COVID-19. You have to realize that the virus, in most instances, doesn't actually kill the person. It's the immune response to the virus when you have a cytokine storm. I differentiate that because some people did die of a viral pneumonia, but in reality, the most severe cases, especially in people where it came on very quickly, was a cytokine storm. And one interesting thing that is there in terms of the research, this was from 2016 with SARS-CoV, if you had an early interferon signal, you had mild disease. If you had a strong interferon that was delayed, that was the trigger for severe disease. But here is the really important point. If there was no or a weak interferon response, you also got mild disease. This is critical to understand because the cytokine storm will occur with a strong and delayed immune interferon response. When we have the immune system so tied up with interferon suppression, we are unlikely to see that kind of cytokine storm. And this is what's lulling people into a false sense of security, because they are thinking that, well, no problem. We have gotten past the issue. There is no longer a cytokine storm. But that's because the interferon is suppressed and the immune system is being depleted. So let's break down very quickly what each stage looks like. I'll be going into more detail on each stage as I go through the sections, but here is a quick overview if you've just watched the first part. The first stage is the persistent infection. These could be anyone, so to speak, with weak interferon responses. Outwardly normal, but they're always run down, recurrent mild viral illness. That's the first stage, persistent infection. The next stage is immune dysregulation. These people sometimes are not necessarily older, higher proportion of women, and again, they're having multiple odd symptoms, rashes, joint pains, palpitations, unpredictable health, good days, bad days. This is stage 2. In stage 3 is what I describe as smoldering inflammation. These are the older people, middle-aged, with metabolic risks, obesity, diabetes, hypertension. And these people, oftentimes low stamina, brain fog, post-exertional crashes, microclots. This is stage 3, and where a lot of people are as well at present. Stage 4 is the older cohort with multiple comorbidities, frail nursing home residents, repeated infections, anorexic, fatigued, poor gait, loss of appetite. That's stage 4. And then in stage 5, end-stage viral sepsis, that's where you have the terminally ill, usually older, frail person, advanced immunosuppressed, and then there is a gradual wind down of the system with multi-organ dysfunction, and this is stage 5. As I said, lots of the population are in different phases. The problem is they will move from phase to phase to phase to phase. This does not happen quickly. And part of the difficulty when we look at the case presentation that I'll be doing later on in a patient who was HIV positive with a chronic COVID infection, the time frame from the initial infection to the final terminal stage of the disease was 14 months. So you realize that when you consider this picture, the transition may not occur in months, but it may be years. And this problem is that if we don't have a way to manage this, what will happen is the surge of deaths eventually. This is the serious part that we have to address. But here is the point I will leave with the first section with you. A lot of people have the idea that it isn't their problem. Sometimes they are unvaccinated in good health, or sometimes they are vaccinated and haven't had any issues. They are not worried, they think, because they don't have to worry about COVID. They are right. But guess what? This is where it is now very, very serious. At population level, outside of recurring exposure to the virus with chronic sepsis, we are now going to see resurgence of very serious diseases. TB, multi-drug resistant TB, because many people who are immune compromised will no longer be able to control the latent TB, and believe me, they can pass it on. Candida, fungal infections, aspergillus, very high mortality, and it's spread from person to person. You have herpes viruses, driving cancer and autoimmune flares. And so one of the challenges that people need to realize is, worryingly, we are all in this together. We have to find a way, because if there is no way to protect the ill will eventually make the healthy ill as well. That is the most serious issue that we have to address. And somehow we've got to find answers for it. Thank you very much for listening. For who are with me on YouTube. And I'd encourage you to look out for the full presentation, whether it's not on Substack or otherwise. Thank you very much, and we look forward to sharing more information with you. Look in the description for more connections.
A hero, an immune adventure. Humming Heroes, your lyrical guide to the body's defense.